Hello, everyone. This is Vijay Batuman. I'd like to open today's special presentation with a special guest, Dr. Quinn Capers. Dr. Capers is a guest of Dr. Handel, so I'm going to turn it over to Dr. Handel to introduce our guest speaker. Bob?
Thank you, Dr. Bodeman, and welcome and good afternoon. It is our pleasure to have Dr. Quinn Capers with us today virtually. Dr. Capers IV is a professor of clinical medicine, interventional cardiology, medical educator, and the vice dean of faculty affairs at The Ohio State University College of Medicine, and has been recognized as a transformational leader in academic medicine. A native of Dayton, Ohio, Dr. Capers is a graduate of Howard University and the Ohio State University's College of Medicine, completing a degree in internal medicine residency and fellowships in vascular biology research, cardiovascular medicine, and interventional cardiology at Emory University. He is a passionate advocate for diversity enhancement in medicine as a strategy to reduce healthcare disparities, as was instrumental in a dramatic turnaround in the diversity of the OSU's cardiology fellowship training program. From 1955 to 2007, Ohio State never had trained an African-American cardiologist. Shortly after his arrival, he led the fellowship program to become one of the most diverse in the nation, culminating in OSU's recognition by the Association of Black Cardiologists in 2012 as one of the nation's leaders in diversity in cardiology. He is extending this commitment to the diversity in cardiology profession as the inaugural member of the American College of Cardiology's Diversity and Inclusion Task Force. Serving as admission dean at OSU's College of Medicine from 2009 to 19, he led to become one of the most diverse majority medical schools in the country while keeping the average MCAT scores for the entry class above the 90th percentile. His recent study documenting the presence and extent of unconscious racial bias in medical school admissions is highly quoted and has led to innovations to perform implicit bias reduction workshops for admissions committees. He has led these types of workshops and trained over 1,000 physicians in strategies to reduce bias. A highly decorated educator, Dr. Capers has won numerous teaching and mentoring awards, including the Professor of the Year Award from the graduating class of 2019, the college's highest awards. His publications focus on interventional cardiology procedures, healthcare disparities, racial bias in medicine, and diversity. It is indeed a wonderful pleasure to welcome my colleague, as well as me serving as one of his disciples. Today's topic is implicit bias in clinical decision-making. Thank you very much, Dr. Capers, for joining us.
Thank you very much, Dr. Handel. Thank you for reaching out to me and being so kind enough to invite me to visit your institution. It's a real pleasure. Hello to all of you there in New Orleans. It's really my honor to be with you today to talk about implicit bias in clinical decision-making. Now, we're all aware of what this is. Implicit bias is this notion that I find fascinating, that we all have unconscious likes or dislikes that are operating outside of our awareness. But even though they're operating outside of our awareness, they can influence our decision-making. Now, where do these associations come from? They come from images all around us that we've been taking in our whole lives. Our brains look for patterns. And when our brain sees two things that are often seen together, it will associate them or couple them. And let me give you some examples. If every time or most of the time I've seen a woman dressed as a Catholic nun, she was doing something kind, warm-hearted, and compassionate. If I see that enough times, my unconscious brain will make the connection that nun equals kindness. On the other hand, when I see a young Black man in a hoodie, I'm always seeing him, or often seeing him, being taken away in handcuffs on the 6 o'clock news, committing a violent crime, or playing the bad guy in the movie. If I see that enough times, my unconscious brain makes that connection. Young Black man in a hoodie equals danger. Now imagine that these two people come to me as patients. I'm a physician, I'm a cardiologist, and let's say they complain to me of shortness of breath. That's a complaint that I hear a lot. With the nun, because of my unconscious association, I may be very motivated to find out why she's short of breath so that I can help her. So I'm ordering x-rays and CAT scans and PET scans and MRIs and pulmonary function tests. I will stop at nothing because I am so motivated to help this woman. On the other hand, the young Black man in the hoodie comes to me complaining of shortness of breath. And because of my unconscious association, what I might do is take a very cursory listen to his lungs and say, you know, I don't hear anything unusual, so I don't really think you need a chest x-ray. Come back in 2 weeks if you're not better. And I walk home that day feeling like I have treated everybody fairly. Now, we can't ignore what's been happening in the country in the last 6 months, so let me give you that scenario a little bit differently. Let's say that now, instead of a doctor, I'm a police officer, and I'm called to the scene of a crime. I'm told there's a disturbance. When I arrive, I see a nun. Because of my unconscious association, the first thing I might do to that nun is smile and talk to her in very gentle, polite tones. Good morning, sister. What seems to be the problem? How can I help you today? On the other hand, I arrive to the scene of a crime and I see a young Black man in a hoodie standing there. Because of my unconscious association, first of all, I'm not smiling. Second of all, if I talk to him, it's not in hushed, quiet tones. I'm barking at him, maybe military style. And because of my unconscious association, I just might approach him with my hand on my firearm or my hand on my taser. That night at dinner, my family asked me how was my day, and I say, I had a great day treating everybody fairly. Because in my conscious mind, I really have treated everybody fairly. That is the power of implicit bias, that these unconscious associations can impact our behavior and we don't even know it. We all have them. It is simply how the brain responds. It turns out you can test yourself to see what are some of your unconscious associations. I hope many, if not most of you, have taken the computer-based implicit association test, or IAT, which can be found by, you can just Google implicit association test, or you can Google Project Implicit. When you go there, you'll see that there's a whole menu of IATs that you can take. You can take one to see if you have a bias against a certain race, gender, sexual orientation, obesity, against the elderly, etc. But it really is an interesting exercise in self-awareness. So I'd recommend that you take one or more of these if you have it. Don't worry, you are the only one that will get your results. Well, these results on this test, believe it or not, have been associated with discriminatory behaviors in the criminal justice system, in the education system, and in what we do every day in the healthcare system. What I want to do now is give you some examples of these images around us that can form the foundation for these implicit biases. What you're looking at here is an ad for an airline and an airline's new mobile app device. It is an app that allows you to track your flights on a multi-stop flight and track your luggage. In other words, if you wind up in your destination city and your luggage isn't there, you can look on the app and see to which airport was your luggage mistakenly sent. The benefit of that app is seen here on the ad. If your meeting is rescheduled, change your flight plans. If your flight's running late, you can reschedule your meeting. Or you can look and see where your lost luggage is. That is the benefit of this app if you're a man. If you're a woman, apparently the benefit of this app is you get to keep an eye on your favorite shoes. Where are they? Where are my shoes? Now, I know what you're thinking, but I don't think that the advertising executives meant any psychological harm to women when they did this ad campaign. But we could take up the rest of our time discussing that. I'd rather have you think about the impact this has on our unconscious mind. If you and I see this kind of thing often enough, our unconscious brain will make that connection, that this is the truth about the universe. Here's another example. A physician was driving in Savannah, Georgia. She's on Twitter. She saw this billboard, took a picture and put it on her Twitter page to stimulate some discussion. And it did, it stimulated some discussion, all right. If you can't see it very well from where you are, on this billboard, are pictured 3 white males. They're all wearing surgical caps and masks. The only print on the billboard says all cardiothoracic surgeons look like this. That's it. And I know what you're thinking. You're thinking, well, first of all, that's not true. Second of all, what? And third of all, what are they selling? What is the purpose of this billboard? Again, we could take up the rest of the hour discussing that. But what I'd like you to think about is the unconscious mind of the little girl who lives across the street and who sees this every day. If she sees this enough, her unconscious brain will say, this is the truth about the universe. And what I want to do now is show you a video. So if you're watching this on your computer or your tablet or your phone, if you need to turn your volume up, turn your volume up. I'm going to show you a video, and here's the setup. The video is an actual news clip from a local news station in Chicago after the shooting. There's been a shooting, and there have been many shootings in Chicago. We all know they really suffer from a lot of gun violence. But they're going to interview in this clip a 4-year-old little boy. I want you to pay attention to what you hear the 4-year-old little boy say, okay? So turn up your volume if you need to. Here's the video clip.
2 teenagers are wounded on the city's south side. It happened at East 74th. As an 18-year-old man and 16-year-old girl were hit while standing on the sidewalk. Male's in good condition while the girl's expected to recover. And kids on the street, as young as 4, were there to see it all unfold and had a disturbing reaction.
No, I'm not scared of nothing.
When you get older, you gonna stay away from all these guns?
No.
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 What do you want to do when you get older?
I'm gonna have me a gun.
Because I live right here and I don't want none of my family members to get shot.
That is very scary indeed. So far, no suspects are in custody.
Okay, so there's been a shooting. This little boy witnessed it. He saw somebody get shot. His response is, I'm going to get me a gun. So think about that for a minute. Think about how that makes you feel about that neighborhood. And think about how it makes you feel, if we're being honest, about those people, right? What's wrong with them? Is it in their DNA? Look how young it starts. His response to seeing someone shot is, I want to get a gun too. What I want you to do now is watch a little bit longer video, the same interview, the same little boy, but a little different perspective. Turn up your volume if you need to.
I like to hear. You ain't scared of nothing. Damn. When you get older, you gonna stay away from all these guns?
No.
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 What do you want to do when you get older?
I'm gonna have me a gun.
You are. Why you want to do that? You know what happens?
I'm gonna be the police.
Okay, well then you can.
So what he was saying was, I'm going to have a gun because I'm going to be the police and protect my neighborhood from this kind of crime. Yet somebody made the decision to take that raw footage, and right after he says, I'm going to get me a gun, cut it right there and show it like that to millions in the Chicagoland area. And I know what you're thinking, but again, I only have an hour with you, and we could spend the rest of our time talking about what could the motivation possibly be of the editor who decided to edit that footage that way. And not only the editor, but I assume somebody had to sign off on it, so their supervisor. But rather than spend our time on that, I'd rather ask you how you think that impacts the unconscious mind of the millions in the Chicagoland area who are watching that. Because that's what our implicit biases are. They're based on all of the images and stimuli that we take in. Well, let's go to New Orleans. Several years ago, Hurricane Katrina. What you're looking at are photographs with their accompanying captions on internet news sites of the Associated Press. What you might remember about Hurricane Katrina, nobody in the world knows about this more than you do, because this was a tragedy, tragic proportions, right there in your beautiful city. What you might remember is that in addition to those who died of direct damage from the hurricane. There were some, in fact, a good number, who died of starvation. They survived the hurricane, but because the emergency management response team took so long, they were found in their homes and had died of starvation. So I want you to imagine that you're in your home, and in your home, you and your family have survived the hurricane, but there's no food. The power's out, and days go by with no food. You literally feel like you're starving to death, and you happen to know that around the corner is a grocery store. What would you do? You would do, I suspect, the same thing that I would do, the same thing that these people are doing. But look at the captions that accompany these pictures. The one up top with a black person says a young man walks through chest-deep floodwater after looting a grocery store. The one at the bottom with two white people says two residents wade through chest-deep water after finding bread and soda. Looting, finding. But they're doing the same thing. If you and I see this kind of thing often enough, over and over and over again, our unconscious brain, in an attempt to help us out, couples these concepts. And what I'd like you to do now is imagine you're a newborn child. You're a newborn, and I'm in control of the images that you see. You don't get to see any images but the ones I show you. And the ones I show you are the ones that I've just shown you. What would your unconscious brain think is the truth about the universe? Your unconscious brain would tell you that while men think about their meetings, women think about their wardrobe. That women are not cardiothoracic surgeons. That while black people loot, white people find. And that black male equals danger. And here's probably the most important point that I have to try to impress upon you. You don't have to be a bad person for your unconscious brain to make these associations. All you have to be is somebody who grew up seeing these images. You can have the most egalitarian heart, yet your unconscious brain has these associations, and that can impact your behavior. So what about physicians? Are we immune? Are we some kind of superhuman being? At times I'd like to think so, but alas, we are not. And we have these implicit biases too. So that website I told you about at Project Implicit, where you take the IAT, tens or hundreds of millions of people have taken those implicit association tests. In this study that I'm showing you here, Janice Sabin and colleagues tapped into that database in 2009, and they looked at the Black-White race IAT, and they looked at the results based on occupation. Those specifically they were interested in who said their occupation was physician versus everyone else. So let's start with the everyone else group. In the everyone else group, the non-physicians, the proportion who had a test result called implicit white race preference. Now, what implicit white race preference means is when I see a white person's face, my automatic association is with good and positive things like family, joy, and love. And when I see a black person's face, my automatic unconscious association is with negative things like pain, violence, fear, and misery. The proportion of non-physicians with implicit white race preference, 70%, 7 out of 10. How about physicians? Would you like to know the proportion of physicians with implicit white race preference? 70%, 7 out of 10. So there was no difference between physicians as a group and non-physicians. Interestingly, there was one group of physicians that was overall neutral, and that was black physicians. Black or African-American physicians, a number of them had implicit black race preference. A number of them had implicit white race preference, but as a group, black physicians were neutral. Whereas the groups of white physicians, Asian physicians, and Hispanic physicians had mild to moderate levels of implicit white race preference. Now, that doesn't mean every individual in those groups, but as a group, those physicians had that bias. Now, what you and I want to know is this just some result on a fun computer game, or does it really mean something about how we treat people? There's evidence that it does. In this study, resident physicians, so they're not even full attendings yet, resident physicians, over 200 of them took the implicit association test. And then they saw a case study or a vignette of a man having a heart attack. Now, they weren't told the true purpose of the study. They were told the purpose of the study was to see how up to date you are on the treatment of acute coronary syndromes. Half of those residents were shown the photograph of a Black man. The other half were shown the photograph of a white man. But the clinical vignette that they all saw was the same. Mr. T is a 50-year-old male smoker with hypertension who presents to the ED having a heart attack. They even discussed his EKG, which an emergency medicine or internal medicine resident would know, clearly showed an ST segment elevation myocardial infarction. The residents were less likely to treat the Black man with thrombolytic therapy, as you know, the clot dissolving drug that opens the coronary artery, stops the heart attack, and saves the life of a heart attack patient. They were less likely to treat the Black man with that drug than the white man with that drug. But the clinical vignette was absolutely identical. When the researchers tried to see, with all the data that they had in front of them, what was the strongest predictor of the decision not to treat the Black man, it was the residents' implicit negative bias about Black people. So this is pretty powerful stuff. It suggests that when you and I see a patient, we might have an unconscious negative association with what we're looking at. Obesity, whether or not they're elderly, their race, their gender, their religion, their skin tone within race. And if we have a negative association, it just could influence us to withhold potentially life-saving therapy. Now that was a simulation. It was, after all, looking at a photograph and reading a case study. This study, though, is real life. In this study, 18 oncologists took the Black-White IAT, and over several weeks, they then went about seeing their patients and saw over 100 Black patients. These oncologists and the patients consented to having the office visit videotaped. And there were three really important findings in this study. The first finding was that those oncologists who had implicit white race preference, the duration of their office visit with their Black patients was shorter than with their white patients. The second finding was that if the doctors had implicit white race preference, their communication style with those patients was what we call verbal dominance, meaning I'm doing most of the talking, I'm not asking you if you have questions, and in fact, when you try to ask questions, I'm kind of cutting you off and talking over you. And then the third finding was that when they had the patients fill out patient satisfaction surveys, there was an inverse relationship between the doctor's implicit white race preference and the Black patient's satisfaction with that office visit. Fascinating, because it's not like those Black patients knew, I didn't enjoy this visit with Dr. Jones because he has implicit white race preference. They don't know that, but there's something in that communication style. There's something happening in that room that really left them with the feeling that I'm not so sure this doctor has my best interests at heart. I have a question for you. Have you ever seen a patient, either in the inpatient setting or the outpatient setting, and you found yourself afterwards saying, you know, for some reason, I can't quite put my finger on it. For some reason, we didn't connect. I went in there with my same humanitarian heart that I always do. But, you know, for some reason, she just seemed like she didn't trust me, or maybe I didn't trust her, or some way we just weren't connecting. It could be that that was a time when you were unknowingly, unconsciously, negatively biased against that individual. And it is also possible that they could sense it too. Well, that's jarring enough, knowing that physicians who take an oath to do the very best we can for our patients and who are humanitarians, we go into this field after all because we want to help people. It's quite jarring to know that because of our unconscious associations based on images that we see around us, that we might treat people differently, less compassionate because of these unconscious biases. But I think what's underappreciated is that doctors have explicit biases too. So that implicit association test, it actually asks you to divulge what are your explicit biases that you are aware of, that you are conscious of. So in other words, if you take the obesity IAT, it starts by asking you this question: which of these best describes you? I like obese persons, or I dislike obese persons, or I'm neutral. You have to choose one. The test won't start until you choose one. So that means that every study you've read about physician implicit bias, if you read closely, go back and read those studies again, you'll see that they also talk about physicians' explicit bias, and it's never zero. In fact, white, Asian, and Hispanic physicians, again, as a group, not necessarily every individual, as a group, those groups have self-reported mild levels of explicit anti-Black bias. Even our trainees, even our medical students have self-reported explicit negative attitudes towards Blacks. And I know we're here today to talk about implicit bias, but I just had to take the opportunity to point out to you that the bias is not always implicit. Some of it is explicit. So we've talked about so far biases triggered by seeing a human or seeing a photograph. But there's evidence that our biases can be triggered by words on a page, just words on a page. And let me show you what I mean here. Here's an example that shows it quite well. This study, the subjects of the study were, unbeknownst to them, law school professors. The researchers sent out to law school professors an essay that they told them was an example of an exercise in legal writing in their class. And they said, we need your help. Would you please help us grade these papers? This is a legal exercise, and here's what we want you to do. We want you to count up all the legal errors that you see, errors of legal analysis, not typos, not spelling errors, but errors of legal analysis. And write whatever you want to on this paper, give us your thoughts, and send it back to us. Half of those law school professors were sent an essay that was labeled Thomas Meyer, Caucasian male. Now, the researchers hadn't said anything to the law school professors about race, but when they got the essay, that's how it was labeled. The other half got Thomas Meyer, African-American male, but the essays were otherwise identical. The researchers intentionally inserted 22 errors of legal analysis in the essay. Here's what they found. When the essays came back, these were some examples of what was written on them. Let's go with Caucasian Thomas Meyer first. It said, generally a good writer, needs to work on a few things, has potential, and good analytical skills. African-American Thomas Meyer, on the other hand, had writing of needs lots of work. I can't believe he went to NYU, and average at best. I'll remind you, it's the same essay. And those 22 errors that were intentionally inserted, on average, 10 errors were found in Caucasian Thomas Meyer's paper, and on average, 15 were found in African-American Thomas Meyer's paper. Here's an example that tells us that what could be happening is that if you have an implicit positive bias about white people, that you associate white people with good and positive things like deserving and intelligent, that when you read their essay, or let's say application to medical school or application for residency, or application for fellowship, you might not count all of the errors you see. You might see an error or two and say, well, we all make mistakes. We don't necessarily have to count every error. On the other hand, if in your unconscious mind, you associate Black with less intelligent, less deserving, and negative concepts, then you might read the essay much more critically, looking for mistakes. And that is apparently what happened here. So I think this is so important. I wanted to be sure and show you this study as we are now either in or about to go into interview season and application season. Some of you are reviewing applications for medical school or for ERAS. And I just wanted to make the case that we don't always have to see a human to have our implicit biases triggered. They can be triggered by words on a page. In this case, the word on the page is race. As you know, on ERAS, the applicant's race is right there. On the medical school applications, the applicant's race is right there. So how do we interact, because it is interview season, with someone who's from a group against which we are unconsciously negatively biased? We know the answer to that question based on social psychology research. When you and I are interacting with somebody that is in a group that we're unconsciously negatively biased against, we allow them less time to speak. So you've already heard a little bit about that. We smile less and we have less eye contact. So just imagine for a minute, let's imagine that you are interviewing for a residency or fellowship, or to be the division chief or the department chair or the CEO or the university president. And the person interviewing you is not smiling, they're not giving you any eye contact. And when you try to ask a question, they're over talking you and cutting you off. How are you going to feel about that interaction? Likewise, what if you're a patient? So one day we'll all be patients. So what if, we flip the doctor-patient relationship and you're the patient and your doctor is not smiling or giving you eye contact and is cutting you off when you try to talk? How do you feel about that interaction? You and I might be doing this unknowingly based on these unconscious biases. And remember, apparently 7 out of 10 of us have implicit white race preference. Well, as you heard in the introduction, one of my interests is medical school admissions. I was the Dean of Admissions here at The Ohio State University College of Medicine for 10 years. And we knew a few things in 2012. We knew that physicians have the same level of implicit bias as do non-physicians. And we also knew that the majority of members on most medical school admissions committees are physicians. Sure, we have other people on the admissions committee. We have PhD scientists and we have medical students, but the majority of our admissions committee, and I'm sure yours is the same, are physicians. What we didn't know is, do those physicians on the admissions committee have those same implicit biases, and might it be impacting our efforts to enhance diversity in our medical school student body? So we had all 140 members. Yeah, we got a big admissions committee. We have 140 people on our admissions committee. We had every member of the admissions committee take 3 IATs. We had them take the Black-White. We had them take a very interesting gender career stereotype IAT, and we had them take the sexual orientation IAT. A word about our admissions committee, 140 people. We have gender balance, and we have both medical students whose average age is 23 and medical school faculty members who, well, let's say their average age is a bit older than 23. So that's important. So one of the tests we had them take was the gender career stereotype IAT, which looks to see if unconsciously you associate either a man or a woman with either career or homemaker. Here are the results on that test of the OSU College of Medicine Admissions Committee. The graph is showing you the proportion of people in each group, students, faculty, men, and women, who have an implicit male career stereotype. So let me talk a little bit more about what that means. If you have the male career stereotype, what that means is that your unconscious brain associates men with career persons and associates women with homemakers. So as you can see, 50% or more of our admissions committee have this unconscious association. And I know those of you who are very sharp-eyed see what we have been scratching our heads about ever since we got the result in 2012, that actually all women, every last one of them, whether they were a 23-year-old student or an older faculty member, were all had this bias where man equals career and woman equals homemaker. We're not the only ones with that finding. Here's a recent study done on surgeons at Stanford University and surgeons who have taken the implicit association test. What they found is that surgeons unconsciously associate men with career and women with homemaker. Interestingly, like us, they found that those associations were even stronger amongst women surgeons than amongst male surgeons. So the question that we have, the concern that we have, the concern that you have is that does that put this young lady at a disadvantage when she's applying for, let's say, a surgery residency, or when she's applying to medical school? She's doing what she's supposed to do. She's smiling, she's making eye contact, she's leaning in, right? Isn't that what we tell women to do? But if her interviewer, who is a good person, I know my admissions committee, they're wonderful human beings like you and me. But if when this interviewer looks at her, he sees homemaker, now this is all happening at the unconscious mind level, then I wonder if he's grading her interview answers the same way. And I wonder if she is at a disadvantage. That's what we are concerned about. We also had them take the Black-White IAT. And as I said before, the first question on that IAT, and you know this if you've taken it, is this: what best describes you? I prefer white Americans to Black Americans, or I like white and Black Americans equally, or I prefer Black Americans to white Americans. You can't skip the question. You must answer that question. It records your answer as your explicit bias, and then the test begins to see what is your implicit bias. Well, here are the results of the OSU College of Medicine Admissions Committee. The graph is showing you the proportion of people with white race preference. 52% of the women on our admissions committee have implicit white race preference, which again means white is good and Black is bad. And 64% of the men have that unconscious white race preference. What are these small bars? These small bars, you got it, they represent explicit white race preference. So yes, that means that 10% of the women and 10% of the men on our admissions committee answered that initial question that I prefer white people to Black people. And remember, this is the committee with the awesome responsibility of deciding who gets to be a doctor, who gets to be a doctor and who doesn't. Imagine what it could mean for the diversity of our physician workforce if half of our admissions committees, when they see this, and I'm pointing here to a Black person's face, they associate this Black person's face with negative things. So this is Ohio State. How about at Tulane? What would this look like if your admissions committee members took the IAT? Or what would it look like if your residency selection committee took the IAT? Well, what I've shared with you is concerning for us, because our concern is that this young man interviewing for medical school has a fair-minded faculty member, but when that faculty member looks at him, if he unconsciously associates him with a violent image, that it might really put this young man at a disadvantage. We wrote about this and published it. And what I've shared with you is what some would consider the negative side of that research, that half or the majority of our admissions committee have an unconscious anti-Black bias, pro-white bias. But there's a positive side. And the positive side is that at our annual admissions committee orientation, we reviewed our aggregate data and went right into an implicit bias mitigation workshop. the very next class we admitted was the most diverse class in the history of the Ohio State University College of Medicine. So the good news is we can override our implicit negative biases. And we end our workshops with these 4 strategies. And these strategies have been proven by research to mitigate the impact of our implicit biases. Number 1 is called common identity formation. This one takes advantage of the fact that we all belong to certain groups. And when I say groups now, I don't mean race or gender. I mean groups like grew up on a farm, plays a musical instrument, groups like that. It turns out if you're in that group, you automatically have a bond with others who are in that group, and simply knowing that can actually inhibit the negative biases that trigger our biases. So that is a strategy. Now you might say to yourself, well, I do that all the time anyway. When I'm talking to my patients, in order to break the ice, I ask them, hey, what do you do? And if I find out that they like fishing, I say, well, I like fishing too. And it helps me communicate with them. That's excellent. Keep doing that. You might not have known it, but that actually is an anti-implicit bias strategy. So keep it up. Number 2, perspective taking. Force yourself to see the world through the eyes of this person with whom you are interacting. Doing so, you develop empathy for that person. And when you do that, empathy actively opposes unconscious bias. The more empathy you develop, the less room for unconscious negative bias. So simply forcing yourself through that exercise of let me try to feel what it is like to be this person. Number 3, consider the opposite. After reviewing the data and coming up with a disposition, call a timeout, re-review the data. And in this case, you're forcing yourself to find evidence to convince you of the opposite conclusion. Now make a decision. That exercise has been shown to neutralize our implicit biases. Finally, counter stereotypical exemplars, thinking of people you know that are in this person's group with whom you're interacting that have traits that you admire is actually a strategy that can reduce your unconscious negative bias against that person. So if you and I have a bias against, let's say, group X, there's somebody on planet Earth on group X that we admire. Now, maybe it's somebody that we don't have access to. Maybe they're an athlete or entertainer, but if we think about them, if we read their memoirs and look at their interviews on YouTube, just focus on that one person in group X that we admire, our implicit negative bias against the entire group actually goes down. We wrote this paper on how to operationalize, if you will, implicit bias mitigation in a stepwise manner in our candidate selection processes and in our patient care activities. And here's one of those steps. We put together an implicit bias reduction cheat sheet, we call it, that is nothing more than a laminated piece of paper that has on it those strategies that I just read to you. And we actually ask our interviewers to review that minutes before the interview. So here is an admissions committee interviewer, but this could be a residency program selection committee interviewer or a fellowship selection committee interviewer. And in addition to having the credentials of the candidate in front of him, he's got this cheat sheet. And so we asked him to cram in these implicit bias reduction strategies minutes before the interview. We found that to be helpful. What I want to do you now, with just a few minutes that we have left, is give you just a taste of our implicit bias mitigation workshops, which we do in a case-based manner. What we do is role play, and the purpose of the exercise is to practice this. When you walk into the room or you pull up on the screen that person, force yourself to be brutally honest and start counting what implicit biases could trip you up. In other words, if I walk in the room to see a patient or to interview a person or have that person on the screen, if it's a tall Asian male with messy hair, I force myself to say, okay, Quinn, I might have an implicit bias against tall people. I might have an implicit bias against Asians, and I might have an implicit bias against people with messy hair. So now that I've taken an inventory of what implicit biases could trip me up, the next step is to use those implicit bias reduction strategies. So very quickly, this is how we do these workshops. So we say, you and I, let's say we are on the urology residency training program selection committee. So of all of our applicants, you and I choose whom we're going to interview, and of those that we interview, whom we're going to rank. Here's our candidate, William. He's a white male from rural Kentucky. He went to University of Louisville. His step 1 score is 208, which, as you know, is passing, but low. He didn't do research, but he volunteered in a free clinic. And I've got something here about his letter of recommendation. So the strategy is for you and I, because we want to be fair to William, we are proactive and brutally honest about what implicit biases could trip us up. And here are some that I've written down. We might have an implicit bias against Caucasians, against males, against people from a rural area. We might say, well, University of Louisville is not a top 20 US News and World Report medical school, so we have a bias against that. We might have a bias against his step 1 score, and the fact that he didn't do research. And then look at him. As you know, photographs are on the ERAS application. So we do get to see them even before the interview. He's got that emblem on his blazer, which might trigger some biases in us to think that he's preppy or he's in some exclusive club. So these are the implicit biases that could trip us up. And now if we use implicit bias mitigation strategies, let's start with common identity formation. William is a swimmer. If I'm a swimmer and William is a swimmer, simply knowing that reduces my implicit bias against William. Perspective taking. Let me try to see the world through William's eyes. What was it like growing up in rural Kentucky wanting to be a doctor? Maybe he went to under-resourced schools from kindergarten through the 12th grade that didn't do a good job of teaching him test-taking skills, and he's still suffering from that with his low step 1. However, he graduated from college. He's about to graduate from medical school. So he's done a lot with a little. In medical school admissions parlance, we call that distance traveled. He's got a great distance traveled. If I think about it in that term, that reduces my implicit negative bias against William because I've developed empathy for him. Finally, consider the opposite. I've done a first pass. I'm going to vote no because he didn't do research. He went to a school that's not top 20. And he's got that low step 1 score. Now let me re-review the data. And what I'm trying to do now is pick out things that actually speak for William's candidacy. Well, he didn't do research, but he volunteered in a free clinic. He didn't have to do that. I like that. The letter recommendation actually says that he does a good job of connecting with patients with rural backgrounds. So these can be some of our most vulnerable patients. And I don't know about you, but I might think it would be a good thing to have somebody in my residency program who does a good job connecting with patients from disadvantaged and vulnerable backgrounds. So if I have to pay for a tutor to help William with the standardized tests, I'm willing to do that. Now that I've considered both sides, that's called consider the opposite, now let me make a decision. And then finally, counter stereotypical exemplars. Let me think of people that I know who are like William, people that went to University of Louisville who I know, and I know some, and they're great doctors, people who come from rural areas who I know, some of them are my family members, and they're outstanding individuals. If I think about them, that reduces my implicit negative bias against William. I just want to quickly take you through one more. Mr. Jenkins is a candidate for kidney transplant, and you and I are on the committee that decides if he will get a transplant or not. He's a 41-year-old Black male. He's been on dialysis for 3 years. He's got a history of medical noncompliance. He's married, he works, and doesn't have reliable transportation. And now let's look at him. And I don't know, Tulane, about your kidney transplant committee, but ours at Ohio State, when they meet in that conference room to discuss the candidate, they put up a photograph of the candidate as they discussed him. So look at Mr. Jenkins. He's not smiling. He doesn't look pleasant. So if we think about the biases that could trip us up, we've got race, his gender. We've got the fact that he's got this history of noncompliance. So all of that might lead me to vote no. But if I do one of these strategies, say, consider the opposite, let me go back through the data I have available. He's been married for 19 years. That tells me he knows how to keep a commitment. And for 13 years, he's had the same job despite not having reliable transportation. So that means to me, if he has to catch an Uber to work or Lyft or the cab or a bus or ride a bike or walk or borrow a neighbor's car, he finds a way to get there. This is a man who keeps his commitments. So maybe if you and I sit down and tell him just how important these medicines are, maybe he is a good transplant candidate. Now let me make a decision. Now it's important to note my decision still might be no, but now I've scrubbed my decision at least of implicit biases. So I hope you found this to be helpful. In summary, implicit biases do not indicate that we are bad people. What they indicate is that our brains are working and doing what they're supposed to do. But they can put people at a disadvantage. And as doctors, that's the last thing we want. And so there are strategies to override and overcome our implicit biases. That will get us closer and closer to what you and I want to do, which is treat everybody fairly. Thank you very much.
Dr. Capers, thank you so much. That was a wonderful presentation. I wanted to take the moderator's prerogative while waiting for a few more questions to come through. And I'll give you a real world, I think, rather challenging situation. And you pointed out that, you know, applications like ERAS for fellowship and for residency do contain a picture and often a box which describes race and sexual preference. On the other hand, you know, that may create the implicit bias you're talking about. On the other hand, we also want to be inclusive and we want to have diversity. And therefore, when we don't have that information, sometimes it is difficult to balance. So how do you look at both ends of that discussion? Because providing that information may create implicit bias. On the other hand, by having that information, countermeasures may be taken for more inclusive practices.
Thank you, Bob. I actually was hoping that you would ask that question. And I didn't tell you to ask that before, did I? No. So a great question, because you're really making a really good point. So I like to say that demographic data, knowing somebody's race, gender, sexual orientation, can be used for evil purposes or can be used for positive purposes. So I'm actually not a proponent of scrubbing the applications of that information. I am a component of all of us being trained in implicit biases and knowing how to try our very best to make sure that we don't have bias in our thought processes and that the bias is not harming the applicant. Because you're absolutely right. If you say, for instance, you're the residency program director for a surgery residency that has never had a woman in 50 years, and you say, we've got to do something about this. We have to have some women because we think it'll make us better. If you scrub gender and the pictures from the applications, you're going to have a hard time doing that. So I am a proponent for leaving it in there, but we all have to be sure that we know how to use bias mitigation as much as possible.
Thank you. We've got a number of questions. One question that just came up: would the AAMC make implicit bias testing mandatory for medical school admissions committees?
That's a great question, and I have actually been coast to coast working with admissions committees to do just that. The AAMC, as you know, is organized into groups, and in the group of student affairs is a national committee on admissions. And I've been talking with some leadership at the AAMC about trying to have the committee on admissions study whether or not they think they would do it. Now, as you know, the AAMC doesn't have the power to make it mandatory, but they could certainly suggest it as a best practice. And I think that would be a definite step in the right direction.
Great. Sort of on a related note, there's a question: this kind of curriculum adjusted for the audience needs to be mandatory for all elementary and high schools, colleges, and graduate schools. Aside from medical schools, is there any traction in rolling this out into other sections?
The next and the most logical traction that I'm aware of is taking it to the GME space, residency and fellowship selection committees. I think and have thought for a long time that college admissions committees should be doing this, and we certainly need it in the educational system. there are a lot of gatekeepers, as I like to say, between kindergarten and medical school in that path. And if you think about it, all the way down in elementary school, the person that works at the school who decides which fourth graders are referred to the gifted and talented programs and which are not, the high school counselor who decides who gets the information about the summer programs, the pre-med advisor in college who decides whom they're going to mentor and give the extra advice. All of these people are gatekeepers, and all of them have behaviors that can be influenced by implicit bias. So I think throughout the academy, from kindergarten on, we need to have implicit bias and explicit bias training.
Thank you. Can you talk about why words like Caucasian, sexual preference, and homosexuality are inaccurate, dated, and harmful?
That's a good question. So I'm not aware of Caucasian being harmful. And so I would welcome a dialogue with the person who asked that question to please educate me a little bit on that. In general, terms kind of have, as we've seen when we're talking about demographics, terms kind of have a lifespan and they kind of reach the end of a lifespan. And at the end of their lifespan, something has given them a negative or less positive connotation. And then we kind of collectively say, we're not going to say that anymore. So we're not going to say Negro, we're going to say Black. We're not going to say Native American, we're going to say American Indian. And so I think that's just kind of the life cycle of certain terms. We have to make sure that our heart is pure, no matter what term we're using. And when we're educating people about just this fact that, hey, that term you used is outdated, we need to do that in an atmosphere where we're really trying to help as opposed to being overly critical. So I'd be interested to know, I mean, if Caucasian is outdated and no longer considered a polite word, I'll have to read up on that. I wasn't aware of that.
Thank you. Here's a very interesting question. On the other side, as a provider, what are some methods you recommend for combating patients' implicit or explicit bias?
Such a great question, because people have written about this, because I'm not sure if it's come to Tulane yet, but when I sit down with my division chief, my annual review includes my patient satisfaction scores, which can impact my salary, which can impact my getting promoted. And so if I, a Black man, am working with a patient population where 7 out of 10 of the people in my patient group have a negative bias against me, then any action I take, they might see it with a negative slant and they might write me bad evaluations, which affects whether or not I get promoted. So what can the providers do? And we really, I'm sorry to say, there's not a whole lot that we can do other than keep delivering the excellent clinical care that you have. But we need to make everybody aware of this. We need to make the people who embed it in our salaries and raises for compensation, we need to make sure that they are aware of this. And people have written on both sides of that. So it is not just doctors that have implicit biases in the doctor-patient relationship. The patients have it too.
Thank you. We have time for, I think, 1 or 2 more questions. Here's one more. Are you aware of any research about implicit bias against people with disabilities in healthcare?
Yes, yes. In fact, if you go to that website, Project Implicit, or again, just Google IAT or implicit association test, you'll see that there's a whole menu of implicit association tests that you can take. And one of them is to see if you have a negative bias against people or persons with disabilities. And yes, research has shown that many of us do, that many of us associate a person with a physical limitation as being less capable, less intelligent, less compassionate, et cetera. So the answer to that question is yes.
Thank you. Well, we have a few more questions, but unfortunately, I think we're out of time. And on behalf of Tulane University School of Medicine and all the people, I think we had about 170 people on the call. We really appreciate you spending the afternoon with us and giving us a wonderful insight into the issue of implicit bias, something that really is very important to all of us. Thank you very much, Dr. Capers.
Thank you so much, Bob.